Good evening and happy Wednesday. Welcome back to Health Plus Weekly. I am Dr. John Pacoa. I'm joined by my co-host, nurse practitioner Hannah Raymond, and we are excited to welcome Dr. Brian Silly of our Internal Medicine and Infectious Disease Department to the show tonight. Thanks for coming, Brian.
Thank you very much for having me.
We have a great show tonight. We are going to talk about, with Brian, a host of common topics in the infectious disease kind of area, including differences between bacterial infections and viral infections, influenza, and I think a host of kind of popular things that people come to see him for, present to their primary care doctors for. And so if you have any questions pertaining to the things we're talking about, please feel free to send them in via Facebook, or also we have a toll-free line if you want to send questions in anonymously that our producer Josh will put up on the screen in a minute. And so let's get into it. Brian, we always like to start with our guests in terms of how they chose their career. So what made you go into infectious disease and how did you wind up practicing in the Southcoast area?
I basically decided on what specialty I was going to go into when I was a medical student. We had to make different rounds for internal medicine, surgery, pediatrics, everything. And during my internal medicine rotation, I ended up seeing a 23-year-old male who had aseptic meningitis, fever, neck pain, was very, very ill. It turned out not to be a bacteria. They knew it was some kind of virus. They let him go from the hospital, and his HIV antibody was negative when he was in the hospital. They did what's called an HIV viral load to see if maybe the antibody just wasn't positive yet. He had plenty of HIV in his blood, and I, as the medical student, got the responsibility to call him and say, it's really important to keep your follow-up appointment. And I said, I would like to be the guy that provides the assistance to these patients who have to deal with serious infections.
That's great.
That's great.
And then you went to medical school in New Jersey. Actually, we're both. But did you go?
I did my college in Jersey and my residency in Jersey, and of course I grew up there. We have that in common.
Yeah.
But my medical school was down in Fort Lauderdale, Miami-Fort Lauderdale area, Nova Southeastern University.
And then you did your infectious disease training
in Providence, Rhode Island. After doing my residency at UMDNJ in Newark, I ended up coming up to Roger Williams Medical Center and spent 2 years over there before relocating to Fall River for about 5 years, and been with you guys in Fairhaven for the last about 2.5.
Oh, it's been great. So I think we were talking before the show. Let's kind of just start with
basics.
The basics.
Yep.
Difference between their infections, bacterial and viral infections, and what does that mean? We talk about it a lot with patients, and in terms of how do we treat them.
Sure, and for anybody who wants to ask any questions, any type of infection, we can talk about. We're going to keep this conversation completely broad. If it relates to any type of infection, we can talk about it.
Awesome.
The smallest known pathogens are viruses, with the exception of prions like mad cow disease. Let's not go too into detail for that one.
Yes.
But viruses are smaller than cells, and they are virulent agents, meaning that they can cause disease, but only with the help of the mechanism that's inside the host's cell. So one might not even say that they're alive because they don't use nutrients. But when they get introduced to a host, whether it be a animal, a human, or sometimes even plants can get viruses, then they can cause disease. Some viruses are short-lived, kind of like the common cold. Some viruses will not go away. HIV, chronic hepatitis C, hepatitis B, these are some viral infections that people can live with their entire lives, with the consequences as the viruses do damage to their system. Mm-hmm. Bacteria are living organisms. They have full cells, and they can live both in an organism and outside of an organism, sometimes depending on which bacteria we're talking about. And those are the ones that respond to antibiotics. Antivirals exist for certain kinds of viruses, like the flu, like HIV, like hepatitis C, like hepatitis B, but most viruses we really can't give any medications for, which is why the common cold will not respond to antibiotics. But if somebody has too much bacteria built up in their sinuses, a bacterial sinus infection will respond to antibiotics.
So that's something important that we see kind of in the office all the time. Are there specific features of illnesses kind of in general, viral and bacterial, that people can kind of distinguish between, okay, I have a virus and now maybe it's a bacterial infection? Like in terms of a common cold versus a sinus infection, what are the distinguishing features there?
Well, sometimes it really is the doctors that would kind of understand a little more than a patient to distinguish a bacterial infection from a viral infection. I hear a lot of times that patients say, oh, what I coughed out or blew onto a tissue is green, so therefore I know I need antibiotics. And that's really a myth. That is just a sign that your white blood cells are producing something in response to an infection. Either a virus or a bacteria can do that. But doctors will know the difference that if somebody is having pain in their sinuses and headaches going on for a couple weeks, along with possibly fever, then those are things that fit more with that bacterial process than fit with a viral process. So for patients, if they're suffering through a respiratory infection, because at this time of year everybody does, then I think that what they should see their doctor about would be fevers. When talking about this time of year, there's a viral process, the flu, influenza, that is characterized by muscle pain, really bad fatigue, sometimes fever, going along with the other kind of things that sometimes accompany a cold, like runny nose and headaches. So kind of when in doubt, get checked out.
Rather than call and just ask for an antibiotic.
It would be really hard for me to tell patients, yeah, these are just cold symptoms and you don't have to worry about it, because I'd be listing a lot, and sometimes bacterial infections overlap with the exact same symptoms.
So best to get checked out when in doubt.
Pretty much.
Are there seasonality to things you see from an infectious disease doctor? I think it feels we are, but so influenza we can talk about is a winter virus, correct?
Absolutely. There is a season for influenza, whereas for pneumonia, one would think that, hey, I'm going to be at bigger risk if I don't take my coat out on a cold day. But as it turns out, pneumonia incidence is actually pretty steady, that there are as many pneumonia patients in the hospital in the summertime than there is in the winter.
Okay.
But some other kinds of things that are seasonal, diarrheal illnesses can sometimes be seasonal. The fall and the spring tend to be the worst for those.
Okay. Is there a reason why fall, spring? Has it anything to do with children and school, or is it?
We think it has more to do with the actual viruses liking that particular environment.
Okay.
So it's actually different viruses that have the peak in fall than the ones that have the peak in spring, yet the symptoms are pretty much the same.
Okay. Let's talk about influenza, because this year has been a particularly bad year for flu. Flu deaths, flu rates of infection. We've tried to kind of raise awareness on the show throughout the season. Fortunately, it seems like there's been a bit of a dip in the activity right now. Have you seen that? And just, maybe talk about, how the flu, what the flu virus is, when it usually occurs. We already didn't know it's a cold weather virus, signs and symptoms, and just kind of some public education about it, because it's important.
The flu generally is worst in the very young and the very old. When talking about flu fatalities, pretty much every year that we look at it, it's always the very young and the very old that are at the biggest risk. So when people are in parenting age, it might be a really good idea to get vaccinated to prevent family members from getting it. In regards to vaccination for the entire population, I say if somebody perceives themselves to be at high risk of getting contact with the flu, then it might be a good idea to protect yourself as well, even if you are unlikely to have the severe consequences. Also, people who have heart disease, lung disease, they should really be getting the flu shot, even with this year not being the best vaccine out of all of them. So let me kind of spend a moment on that.
Please.
Back when we had our most recent worst flu year, the one that was worse than this in our most recent memory, there was a major mismatch with the circulating strain of the flu that was going around versus what was actually in the vaccine. This year, they got it right about what viruses were actually going to be needed to be in the flu vaccine, and yet there's something that we don't quite understand that makes it less useful than most year's flu shots. But if everybody remembers back to 2009, there was the H1N1 swine flu going around back then that resulted in higher complications when people got sick from the flu, and also resulted in a higher incidence because the flu shot wasn't really protecting against that strain. So that wasn't the problem this year, but there's some other problem that we haven't yet identified about why the flu shot wasn't as effective this year.
Can you talk a little bit about how how they make the flu shot? In terms of how the CDC and the World Health Organization kind of go about, and why we need a new flu shot every year. Like, why doesn't it last from year to year? I feel like I get asked that a lot.
There's a question also from Cheryl asking, how do we know what strain of flu will be next, or what goes into the next flu vaccine for the following season?
That one is a complicated question, and it might be too complicated for me to answer, but I do believe that they try to get a sense of what is going on the other side of the world.
The Southern Hemisphere.
So we looked at what was happening in Australia to predict what was going to happen in our winter. But I do believe that for the making of the flu vaccines, they start with a culture of eggs, and that's why people who have an egg allergy unfortunately cannot get the flu shot. And they culture the virus inside of the egg, and then end up making as much of a supply as they can, and unfortunately because of that and the process that's involved, supply is sometimes an issue depending on what year it is. And as far as I'm sorry, I'm missing part of the question.
Right? So the reason why we need a flu shot every year.
Oh, okay, that was the part of the question I was forgetting for a second.
Okay.
On the outside of the flu shot, there are two proteins that kind of stick out that our immune system recognizes. One is called hemagglutinin, and the other one is called neuraminidase. And so each of the flu strains that are around is either influenza A or B, depending on how the overall virus kind of looks and sometimes acts. But then they try to subtype it by what type of H antigen and what type of N antigen are on the outside. And we've been making vaccines based on what is at the tip of the H antigen and what's at the tip of the N antigen. And that seems to change every time there's a new strain that circulates. What they're trying to do different, which hopefully is just around the corner, is make a vaccine against the stock of the H and the N, which doesn't change from year to year. So perhaps we might see one flu shot 5 years from now, cross my fingers that it's only 5 years away, that might last for 10 years, and it might be effective against all strains of the flu. Now, that said, that might be wishful thinking.
Sure. Okay. Are there any other questions before I have a litany of things I want to ask Brian?
Cheryl says thank you.
Timing, like when should we get the flu shot? I think because people get it in the summer, it starts coming out, but it doesn't last the whole a year, correct?
Yeah.
So when should people really think about getting their flu shot?
I'm going to give an East Coast answer here.
Yeah,
October.
Okay.
October is the answer for around here. As it turns out, the West seems to have flu first, and then it eventually gets over here. And that answer might be September, if you were asking that in California.
Okay. And once we get the shot, how long before it works? Like how long? Like I've always told patients about 2 weeks. Is that about right before it offers?
That has been what I have been saying as well, but I don't have a lot of data that's at the top of my knowledge to really kind of back that up.
Okay. And then we see this all the time. Can you get the flu from the flu shot? Why do people think they get the flu from the flu shot in terms of your experience? And obviously it's an inactivated virus, so you do not get the flu from the flu vaccine, but maybe you can feel lousy after getting a vaccine sometimes.
Yes, the immune response that the body initiates after getting the flu shot can sometimes leave somebody with chills, body aches, feeling tired, and you might even be more likely to pick up a different virus on top of that.
Okay.
So say you have those side effects and you get a cold right after getting the flu shot, then somebody who doesn't have a lot of training says, hey, I got the flu from the flu shot, I don't want to have it ever again. But somebody who did get a bad reaction in 1 year with a bunch of chills, sweats, is probably more likely to get that same reaction again. They didn't get the flu from the flu shot though. And perhaps some of the misconceptions about that relate to the fact that there have been different preparations for the flu vaccine in previous years. The intranasal vaccine, I believe, was an attenuated but not completely inactive flu virus. So perhaps they're kind of thinking about previous preparations.
Okay.
Are you still recommending flu vaccines currently?
Actually, at this point in the year, I kind of think with the efficacy of the flu shot not being as good as most years, I've kind of stopped recommending it for this particular flu season. However, different doctors might feel very differently about their high-risk patients. So if somebody has emphysema and their pulmonologist is saying, hey, I don't care what time of the year it is, get your flu shot for the season, you should probably listen to that doctor.
Good advice. Okay.
When people do come down with the flu or virus, I think one of the common things is how do they know when they're not kind of infectious, and how long it's just to stay home, kind of going back to work in terms of, I kind of go by the rule of thumb, if you're fever-free for about 24 hours, it's perhaps safe, and in terms of making sure I'm doing the right thing. And when do you tell people in terms of like that they are not, maybe at risk of kind of doing harm to their colleagues and people around them? Is there a kind of...
I think I have a good answer for people who've gotten Tamiflu.
Okay.
That after a couple days of Tamiflu, I think the risk of passing it on really drops big time.
Okay.
But if somebody didn't get treated with Tamiflu, which of course is the antiviral that treats against the flu, which I'll go into actually a little more after we talk about this, that is a little more tricky. I think that people generally might only have fever for the first couple days, but still could keep on coughing for an additional 3. I'd give it probably more like 72 hours after the fever breaks.
Okay.
So I did want to actually talk about those antiviral medications for the flu. One of the reasons it's important to tell your doctor about if you think you have the flu, if you have body aches, really bad fatigue, feeling like you've been hit by a truck is one of those kind of descriptions that we hear all the time. And I had the flu this year, and I swear that's an accurate description. That with any of those, if you tell your doctor within the first 48 hours of developing those symptoms, Tamiflu is likely to cut that in its tracks big time. So when looking at the study that really kind of looked at that, the duration of the flu went down by only a couple days. But say you're in the middle of that, you're going to be happy that you're not suffering for those couple of days.
Does it cut transmission rates as well? Does it make you less contagious?
Absolutely it does.
Safer for everyone around you?
Yes.
Okay.
Yeah.
Once you have the flu, are you at higher risk for secondary infections like pneumonia or,
The largest pandemic in recent historical memory was the Spanish flu of 1918. And when looking at the autopsies years after the flu epidemic ended, they saw that pretty much everybody that had passed away of the flu actually passed away of bacterial pneumonia. And they probably all developed the flu and then got bacterial superinfection on top of it. And they probably weren't wrong that it was the flu when it started. So that is a risk, and it's believed that different strains of the flu will produce different risks of that. That's why we don't see it most years. But it can happen.
It can happen. How would you know if you're kind of in the flu and then maybe you're getting over it, but then something else has changed? In terms of like when to worry that, when to go back to the doctor in a sense, or maybe that, something's changed. It's no longer just influenza,
So for people that had the Tamiflu, then it's really clear that a couple days after you started, you feel better. And sliding back is something that's abnormal. It is a sign that maybe something is going on top of it, particularly a productive cough. Typically the cough that goes along with the flu brings up a little bit of saliva, but not thick yellow-green phlegm. And for somebody who did not get Tamiflu and had the flu, then I would say the duration of fever that one would expect would be about 3 days. And then if that goes away and then comes back, that's a sign that there's something abnormal happening.
Okay, so like sick, a little bit better than sick again, without ever completely improving is worrisome. Maybe just get checked out.
Absolutely. And worsening shortness of breath is one of those things too, that one usually gets hit hard by the flu at first, and it typically is worst on the first couple days.
Okay.
We have a question from Cheryl about how important is it for newborns to get the flu shot? And if it's important, is it better after the first dose of booster? So could you just speak to kind of the earliest age that somebody could get the flu shot and why it's important for newborns?
Sadly, I'm going to have to say I don't know a lot about pediatric vaccinations because I have not ever really seen pediatric patients. I'm an adult infectious disease doctor, so I'm going to have to say whatever your pediatrician says is probably pretty good advice.
Okay.
But thanks for the question anyway, Cheryl. Thank you.
I had, diarrhea with flu. Typically not classic symptom. People think they get the flu because they have diarrhea, but does flu cause diarrhea?
Flu A does not. Flu B can have a lot of gastrointestinal symptoms.
It can.
Flu B can go along with nausea, vomiting, sometimes loose stool.
Okay. And do you have any other kind of thoughts on influenza or the treatments that before, or vaccines before?
Or debunking media myths?
Yes. Yeah.
Well, one thing that I was hearing in the media a lot this year was mixed messaging about getting the flu shot. This flu shot this year is not going to be effective particularly well, but everybody should go out and get it. That left me confused about the message that they were trying to pass along. So I think that pretty much everybody else who heard that same message would have also been confused by it. So once again, who is going to benefit from a flu vaccine that doesn't work quite as well? The people who need it the most, the very young, the very old, and the people with illnesses that would get worse if they developed the flu. Heart disease and breathing issues like emphysema.
Okay.
And Meredith asked a question, is it too late for me to get the flu shot? And I think you kind of touched on that before.
Yeah, definitely. If your physicians think that your serious health issues warrant protection from the flu this late in the season, it's probably a good idea. But it is late in the flu season to start getting the vaccine. And I do think there's a bit of a delay. We're guesstimating about 2 weeks before there's a major response and a major protection against the flu.
Okay. And flu season tends to wind down end of March, beginning of April. I mean, it varies year to year a little bit, but when's historically flu season done in the East Coast here, or around these communities?
I feel like I have seen it end around similar times in previous years, but I haven't really looked back. I feel it winds down towards the end of the winter, but I don't know if necessarily I want to say February versus March. It's hard to say, but I say as the winter winds down, we're also tending to see the flu rates wind down as well. And luckily, we're starting to see that this year too.
Okay, great. Some other, I think important infectious disease topics we can talk about, and we can go through them, certainly I see a lot of patients, and I don't know about you, Hannah, and you, Brian, but there's been a lot of news coverage and media and commercials about hepatitis C over the past several years. Ask your doctor about, have you been screened for hepatitis C? And so is it okay if we talk a little bit about why those commercials are on, hepatitis C, who should be screened, what it means, and what is hepatitis C, if that'd be okay with you?
Absolutely. Hepatitis C is a viral infection that can be transmitted from blood to blood route. People who received transfusions before the mid-1980s, people who've ever used a needle. Sometimes sexual transmission can occur with hepatitis C. Not that commonly, though, and also intranasal drug abuse seems to be an independent risk factor for obtaining hepatitis C, possibly from microscopic amounts of blood-to-blood transfer. If somebody is exposed to hepatitis C, say somebody ends up getting stuck with a needle that has hepatitis C positive blood inside of it, the 1 out of 5 will be able to fight it off themselves, and 4 out of 5 will not be that lucky and get stuck with long-term hepatitis C disease called chronic hepatitis C. Mm-hmm. That can gradually form damage in the liver that can increase the risk of liver cirrhosis, liver failure, and liver cancer over many decades. It's only 1 in 5 people who are infected with hepatitis C that will have any of those possibilities happen, but that's a bigger possibility than most people would be comfortable with naturally. Sure. And of course it can cause other problems along the way, like decreased energy, skin issues, various other kind of problems in other organ systems that are just unrelated to the liver as well, going along with the chronic viral infection. For years, it was really not easy to treat or cure, and that has changed a lot in the last 10 years. For the duration of the 90s and the early 2000s, we were giving shots of interferon to go ahead and stimulate the body's own immune system to try to fight off the hepatitis C, to make those 4 out of 5 that weren't able to get rid of it themselves kind of more like that 1 out of 5 that was able to fight it off. But as it turns out, for most types of hepatitis C, those treatments caused lots of side effects and sometimes had success rates around 30%, 60%. And people would have to stay on those treatments for months at a time, and a lot of people got sick. A lot of people even died from the treatments. Mm-hmm. Having hepatitis C was bad news, while there weren't a lot of treatments that were around that could really kind of take care of it. What's changed is that we now have pills that work directly to shut down the production of new hepatitis C viruses that can go ahead and be curative greater than 90% of the time, and also with barely any side effects. And when I say barely any, I mean close to the amount that people would get from a multivitamin. Wow. 5% nausea, 5% headache, 10% fatigue. But with only a period of 2 to 3 months, we're able to cure most types of hepatitis C. And the disadvantage, though, about our current treatments is the cost. Each of those new treatments are basically more than $1,000 a pill.
And how many pills are people taking? I mean, so it's
for about 3 months, we are potentially talking close to $90,000.
Wow.
There are even better treatments that have shown up where we can shorten the duration down to 2 months for some people, and some insurance plans have been able to negotiate better deals than that. But it is a big deal when somebody goes through a hepatitis C treatment and then gets stuck by another needle. So that's why for one of the biggest groups of patients with hepatitis C, people with a history of intravenous drug abuse, I want to make sure they have a good amount of time and feel very comfortable with their recovery before getting that first pill of hepatitis C treatment. Because those big risks, cirrhosis of the liver, liver failure, liver cancer, they take decades to develop. And if somebody doesn't have a full year of clean time, it might not be the right time to start hepatitis C therapy in those individuals.
Okay. So even though it might seem like a panic, like you just got diagnosed with it, it's okay.
If you really care about that person's health, you'll be helping them move towards recovery from their opiate addiction and move away from the risk factor that led them to have hepatitis C in the first place, then take care of the hepatitis C infection.
Okay. So people born between 1945 and 1965
Yes. There's a recommendation from the CDC to screen everybody for hepatitis C, and some insurance companies make you be very creative about the billing code so that people don't get the bill for that, because sometimes screening for hepatitis C, even with the national recommendation to screen those people, will still land them with a bill for the test.
Yeah.
So I do recommend that people get screened, especially if their liver function tests are elevated, if they're in that age group. And as far as who else should be tested for hepatitis C, anybody who's HIV positive should be tested for hepatitis C. If you're asking your doctor for an STD screen, it might be a good time for the doctor to order a hepatitis C test as well, even though it's less commonly sexually transmitted than other routes.
Okay. Because like you said, it can be, you may not have the most obvious symptoms. It could just be...
Yeah, most people with hepatitis C do not have symptoms.
Okay.
They either need to go ahead and, if they think that they have been at risk for hepatitis C infection, history of needle usage in the past, they need to ask their physician, hey, can you please make sure that I get checked for hepatitis C? And sometimes that's the way we find it. Or sometimes just in regular blood tests we notice, yeah, the liver looks a little bit inflamed, and that will prompt the testing for hepatitis C. But in the majority of patients that I have both diagnosed with hepatitis C and treated for hepatitis C, there's a lack of symptoms in the majority of them.
Hepatitis A, there's a couple other different types of hepatitis, but commonly, so talk a little bit about hepatitis A.
Sure. Hepatitis A does not cause long-lasting disease like hepatitis C or even hepatitis B, which we haven't talked about yet, and I guess I'll get to that right after this. Hepatitis A can give somebody fever, nausea, vomiting, and turning yellow, and then after a really bad period of time, they typically get better. Although some people will have a more problematic course during that period of time when they have the acute hepatitis A. If somebody has hepatitis C and they get hepatitis A on top of it, that can be a problem because it's not a healthy liver that the body is trying to heal, and the body might have a harder time with that. There's a higher chance of ending up with bad problems from getting hepatitis A if you have hepatitis C. Luckily, there is a hepatitis A vaccine out there, so people that are not ready to get their hepatitis C cured, say because of active IV drug abuse, then they need to get the hepatitis A vaccine to protect them, and also the hepatitis B vaccine.
How do you get hepatitis A?
It is usually a fecal oral route, so somebody who is a chef that's not washing their hands can pass it on to a whole bunch of people. Epidemics have happened that way.
Okay, so not classically like a foodborne illness, but it can be in
food industry.
Food industry.
Yes. Okay. Another kind of a way that it can be fecal oral route is from shellfish in areas of sewage runoff. That has actually caused hepatitis outbreaks from stuff like clams.
Okay.
Although that's not a common thing, we'd be hearing about it a lot more if this were happening on a day-to-day basis. I've never seen a case of that.
Okay.
And of course, we live in a coastal community. I think we know.
Yeah.
So hepatitis B, let me talk about that for just a little bit. Hepatitis B is a major cause of liver failure worldwide. If a child gets infected with hepatitis B, either from saliva, fecal oral route, or blood, then the chances that they will wind up with chronic liver disease and be at a much higher risk of liver cancer is really high. So adults, however, who are exposed to hepatitis B for the first time might get sick when they're first exposed to it, but generally the body pushes it into suppression. And we call those people carriers after the body does push it into suppression. Even those people can get hepatitis B flares if they go on immunosuppressive medications or chemotherapy. So it's important for even those people who are not being affected actively by hepatitis B. It's not causing damage to their liver. It's not putting them at greater risk for liver cancer, but they should still be aware that they've been infected with hepatitis B. And of course, if we see liver functions are elevated, that somebody is with hepatitis B that's chronic, they should be watched really closely because their risk is real for liver cancer and for liver failure.
Can we treat hepatitis B like we can hepatitis C in terms of eradicating it, or do we just kind of is it?
Sadly, the answer is no. One of the good things with hepatitis B is that we can immunize people against it. So if they're negative, they can prevent ever being infected with it. And that's what's really starting to affect the third world at this point, is that vaccination campaigns are really pushing down the worldwide hepatitis B vaccine in the hepatitis B rates in the new generation. But for people with hepatitis B, currently there are medications to push it down into submission to make those people act more like carriers.
Okay.
But no, once somebody has hepatitis B, they can't be cured from it, but we can at least watch and make sure the bad effects don't happen.
Okay, great. Other questions sometimes I hear from patients, and it was in the news, is, and just going back to like kind of foodborne illnesses or outbreaks, E. coli, in terms of how do people protect kind of against that? Can what is E. coli, and why does it cause such these outbreaks? And
E. coli is one of the biggest bacteria that live in the gut of not only humans but also farm animals. Any kind of mammal has E. coli as the main species that's in the gut. And most E. coli is fairly harmless, that it's one of the good bacteria that live there. And there are certain types of E. coli that can pick up what we call antigens that can just change its properties and cause diarrheal illnesses. It can, one particular strain that's pretty well known, can cause the hemolytic uremic syndrome. And I think it was Jack in the Box burgers out in California in I want to say the late 80s, that caused lots of people to have life-threatening infections with this one particular strain of E. coli. When that particular strain or one of the really bad pathogenic strains of E. coli is found, then we definitely act. The USDA acts. Cooking a burger all the way is some protection because it's a bacteria. It dies at really high temperatures.
Good.
Making sure a burger is at least medium cooked is a good way to get rid of not only E. coli but salmonella and other kinds of infections that cause foodborne illnesses. But there have been some outbreaks that have happened actually from vegetables with pathogenic bacteria that's from the soil. That probably got there from farm animals getting too many antibiotics that are nearby that. I think that happens more with salmonella than it does with E. coli, but that's a possibility too. And protecting yourself against that one is a little more difficult.
Okay. So definitely making sure you cook your meats, your chicken, eggs, helps lower your, if not eradicate, significantly lower risk of getting an infection from food.
That's correct, yeah.
What are some other
Sorry.
it's okay, infectious disease kind of issues in this community that you see commonly? So we've talked about hepatitis C, we've talked about a couple of the other hepatitis forms. What else do you see in your practice commonly? Okay.
Let me talk about HIV first, which kind of goes along with hepatitis C and hepatitis B, that they're all blood-borne routes, and if somebody gets stuck with a needle, any of the three could result. And of course, everywhere in America, HIV is around. Of course, that's a sexually transmitted infection, but also can come from blood-to-blood route. And back in the day, when I say that, I mean the 1980s and early 1990s, there wasn't really much hope in terms of medications for people that were infected. And that has dramatically changed at this point. I see a lot of patients with an essentially normal lifespan at this point who are walking around with HIV, yet their viral loads, when we look in a drop of blood to see how much HIV is actually there, to see how their medications are working, we're not finding HIV in that drop of blood. We call that an undetectable viral load, and that is a successful treatment for HIV infection. And there are a lot of HIV patients that are out there in this community that are doing rather well, but if they don't know that they're infected with HIV, their body's going to get weaker and weaker, and we can't always bring them back to where they started if their body gets weak enough into a AIDS state. So that's why if somebody feels like they're at risk for sexually transmitted infections, they really need to get checked out and tested.
Let's talk about screening. So just like, you know what I mean, kind of just really kind of getting it out there and being clear of like who should be checked for HIV, when should they be checked, should be rechecked, just kind of what are your thoughts on it?
I think anybody that just requests a sexually transmitted screen should be tested for HIV, syphilis, chlamydia, gonorrhea, and possibly hepatitis B and hepatitis C. Anybody who has recent needle usage, I say use any opportunity to test them for hepatitis B, C, and HIV, unless you know that they're immune to hepatitis B. And as far as, let's see, men who have sex with men should probably be screened more frequently, and well, their risk of obtaining HIV is higher. So you might even want to bring that up as a clinician to just screen patients who fall into that category.
And then you were going to continue on about HIV, I think, in terms of...
What about those high-risk populations? Is there treatment kind of before, if you're participating in higher-risk behaviors for contracting HIV, is there anything we can do to help you prevent it?
Great question, and definitely that has changed a lot in the past few years. Before, protected sex was really the only way that we had to protect people that considered themselves at higher risk for HIV acquisition. Whereas now, especially in the men who have sex with men population, taking one pill once a day, that's actually an active HIV medication, actually 2 active HIV drugs in each pill, the pill Truvada. Taking that once a day for an HIV negative patient who feels like they're at risk for obtaining HIV through sexual encounters, it has been shown to dramatically drop the risk of getting HIV. But I see patients like that, and I screen them all the time for HIV infection despite being on that medication.
I'm smiling just thinking about when I was a medical student. I worked with a pediatrician in Newark, New Jersey, who was just, you know, fantastic, and I asked her in her, you know, lifetime practice in medicine, you know, so this was in like the 2000s, she was probably, I bet, in like her 60s or early 70s, yeah, probably 60s at the time, what the most significant change was that she saw in her career, and she said, without a doubt, you know, HIV, AIDS, and how it went from being this catastrophic, unknown illness that was killing children, adults, you know, and was like a death sentence, to the success that it is today, that she had, you know, children that were born to HIV positive women that were just, you know, have normal lifespans like you talk about. I mean, sometimes I think we forget, or we look on so much of the negative of the things, but there are miracles right in front of our eyes in terms of modern medicine, what can happen, what we've done, and what we've accomplished. It really is amazing. I have many patients, you know, and you care for, you know, a number of them who are doing great with these medications without significant side effects, without a lot of pills anymore. I mean, it's remarkable, you know, what's out there.
So I mentioned undetectable viral loads, where we can actually look to see how much HIV is in a drop of blood and detect if there's a lot there or basically none that the lab can detect. And treatments that could actually accomplish that were just not around before 1996.
Yeah.
So there were people getting HIV all throughout the 80s and all throughout the early 90s that really had nothing to protect them from the ultimate consequence of AIDS, which was death from AIDS. And that has changed so dramatically since getting these agents on the market. And as time has passed by, they've become less and less toxic. In the very beginning, people were getting side effects like crazy from these medications. And I have to say that there's still people who get side effects from some medications. That happens with all classes of medications. But the percentage and the severity of those consequences have dropped big time.
And I just for the audience and for people to know that that's one of your areas, especially like you take care of HIV patients. So if you're in this area and you either are concerned about maybe having HIV and want to get screened, or have HIV and you can come, right? You're in Fairhaven, and that's what you take care of.
Yes, and even for partners of HIV positive individuals given that pill PrEP, we call it pre-exposure prophylaxis, when somebody takes a medication once daily to prevent getting HIV infection. I see plenty of patients like that who I'm giving an HIV medication to prevent HIV, as well as the HIV positive individuals. And I have to say that if we catch the diagnosis of HIV before the body gets weak, those patients are taking one pill once a day and feeling pretty much normal.
So that's amazing too. So people who have HIV can also have like a normal relationship with someone without putting their partner at harm. Like be kind of working with you.
Yes.
Or HIV specialists to help lower that risk. Right?
Absolutely.
They don't have to remain isolated, or because I have so many patients who are worried about that.
Absolutely. I don't want people to get too cavalier if they're HIV positive and they've been told that their viral load is undetectable by their infectious disease physician to start having unprotected sex. Because what a viral load basically tells us is what's going on at that particular minute in the blood. If somebody has plenty of undetectable viral loads, chances are there's not really many occasions where the virus is actually releasing its supply into the blood and a person becoming infectious. But I have had patients that say, no, I'm undetectable, I'm not worried about it. Then who I have to review, you were undetectable last time, but the time before that you weren't, time before that you weren't, and you're saying you're missing every third day of medications. So I don't want people to be too cavalier if they're HIV positive about their chances of passing it on to anybody else. But with an undetectable viral load, the chances of passing on HIV drop big time, and if their partner is on PrEP, then the risk is nearly nil for passing on HIV to that individual.
Can we briefly just talk about symptoms of if you get HIV? If you're with a new sexual partner, if you inject yourself with a needle, there's symptoms of HIV, correct?
Yes. So that patient that I was telling you about when I was a medical student who had the aseptic meningitis, we call that acute retroviral syndrome. About half the people who get infected with HIV will recall a time when they had a flu-like illness where they have body aches, chills, and of course I'm saying this right after flu season. So everybody's going to say, but say it's not flu season, and there are those kind of symptoms that are around, particularly with a bad headache, bad fatigue,
a rash at all?
Sometimes a rash that kind of looks like measles light. All those things can happen when somebody first gets infected with HIV, and I've had some patients even recently say, you know what, I can pinpoint when I got infected, and then I look at their CD4 count that tells me how good their immune system is, and kind of say, I bet you were right. So, but not everybody will get that, so even without that kind of history, just getting screened if you think you're at risk is going to be a good idea.
Okay, great.
So we were talking about infections here in this area, and we haven't brought up Lyme disease yet.
I was just going to say, a nice chunk of time left. I think that would be great.
Okay.
So, I know we were just kind of talking before, everybody knows about Lyme disease, but there's another tick-borne illness in this area that is kind of unique to this area that doesn't get as much attention. Do you want to just kind of talk about all the tick-borne illnesses?
Yeah, let me talk about the big three.
Sure.
First, nobody in this area has heard of Babesia, it seems, and I think that that's a major shame because we're probably the highest risk area in the nation here in this little corner of Massachusetts. What Babesia is a infection that can be transmitted by deer ticks. Just like Lyme disease, in fact, some people are what we call co-infected. When they get bitten by a tick, the tick can infect them both with Lyme disease and Babesia infection, and they don't respond to the same antibiotics. Babesia is more like malaria, that when we can look under a microscope at red blood cells will have little parasites inside of them from somebody who has Babesia infection. They'll have fever, they'll have chills, they'll have sweats, and sometimes shortness of breath, sometimes abdominal pain, and certainly if it's the time of year that we think of, from spring to fall in this area, although there have been some tick bites that I've seen in my patients even recently, then I think that it's probably a good idea to test for all three. In our institution, we have a tick panel, so I recommend that all the doctors who are considering a tick-borne infection, even if they're only thinking about Lyme with the symptoms that the patient is bringing, to test for all three, a tick panel. So Babesia is one. Babesia causes bad disease in people without spleens and in the very old. It can leave somebody who's young feeling achy and tired and having those symptoms that I just talked about right there. Another one is anaplasmosis. That one does respond to the same antibiotics as Lyme disease. So a lot of clinicians that only test for Lyme disease will be curing their patients of Lyme and anaplasma at the same time, and they don't have to worry terribly much about it. Not all the same antibiotics. I'm saying doxycycline, which most people get when they are treated for Lyme disease, will take care of both. What kind of symptoms go along with that? Sometimes elevation of liver function tests, sometimes pain around the liver. And some of those symptoms with anaplasma are just like the symptoms for Babesia. Chills, fever, sweats, body aches. Lyme disease, however, we know for half the people who get infected don't get a rash, half the people don't see a tick. But some people will experience these symptoms with any of those three infections after a tick bite. With Lyme disease, everybody talks about a bullseye rash. I call it a palm slap rash because to me, it only looks like a bullseye for the last 2 days that it's around, when it starts to fade in kind of the periphery before it fades at the edges or in the center. So if you kind of have something on your abdomen, thigh, lower leg that just kind of looks like somebody just slapped you with their palm, a big oval kind of shape that just won't go away and just seems like a big red kind of area, might itch, but it typically doesn't hurt much. And that might be going along at the same time as having body aches, chills, or headache, then that is Lyme disease. That person doesn't even need to be confirmed on a blood test to treat them for Lyme disease. As a matter of fact, if you have that rash around, I recommend not relying on the blood test to treat for Lyme disease. I recommend getting the blood test only to look for the other two infections that are transmitted by ticks, Babesia and anaplasma.
Okay. So we have a question from Catherine, kind of going along with the first presentation of Lyme disease. Would that person be contacting you? Would they be contacting their primary care? What's the first step?
I definitely feel all practitioners in this area should know how to treat Lyme disease, and that it doesn't take an infectious disease doctor to treat the first case of Lyme.
So when would a case of Lyme get to you?
So we're talking about so far just the early symptoms of Lyme disease that get diagnosed and treated early. For some people who do not get treated early, they're walking around with joint pain, muscle pain, fatigue, or maybe just really more subtle versions of that they don't really attribute to very much. And then they find only, maybe half a year later that they've talked about the symptoms with their primary care physician and the blood test for Lyme disease is positive. They might not respond to the first course of therapy and be cured from the first course of therapy. And when trying to determine whether they were or were not cured with therapy for Lyme disease, it's sometimes very confusing to interpret the lab results. So I say if somebody has been treated for Lyme disease and they're not quite right, and maybe the blood tests are not perfectly clear, then I think it's perfectly reasonable to get an infectious disease doctor involved and take a look at the situation.
So that would be coming from their primary care physician to you as a referral?
Yep. One of the referrals that I see a lot are for people who had Lyme disease years ago and are left with symptoms like fatigue, body aches, headaches. And I feel like those patients fall into two major categories. One are the people who are walking around with active Lyme disease that's still replicating in their body, still causing harm, and still can cause new problems down the line. And I think generally good infectious disease doctors can pick those patients out by doing some confirmatory blood tests. Then the other group, unfortunately, if they didn't get their Lyme disease treated in a timely fashion, their antibiotic might go ahead and get rid of the active Lyme disease in their body, but the infection may have done damage while it was there, and patients might be left with long-term fatigue. They might be left with subtle sleep abnormalities that can leave them tired and fatigued. It's almost exactly like fibromyalgia. So for those patients, sometimes it's better when somebody is in doubt and the blood test is not stone cold negative to get an opinion from an infectious disease doctor.
preventing Lyme disease, it's important, I think, for people to know that if they find a deer tick on them and right, there's something we can do, right? So another reason to kind of reach out to your doctor, right?
So this is only a recommendation for areas that have a high percentage of deer ticks that test positive for Lyme disease, but pretty much everywhere in Massachusetts and in New Jersey, where we're from, fit that description. So in the Northeast, if you get bitten by a tick that you believe has been on your body for a period of time, I'd like to say, anything more than 6 hours, although you'll find places that say more than 24 hours or more than 48 hours. Then 2 pills of doxycycline, 200 milligrams just once, will decrease the risk of getting Lyme disease hugely. I can't put an exact percentage on that because I don't think the data is that good right now. But also probably decreases the risk of getting anaplasmosis as well, the other tick-borne infection that we just talked about.
That's great.
I have a question from Michelle, and so we touched on untreated Lyme and how that can kind of present. What are the other long-term effects of after Lyme disease, if it's been treated effectively? What will people feel?
So a lot of patients that get cured of Lyme disease are not left with any long-term symptoms, but for patients who have severe Lyme disease, it can affect the neurologic system. People can be left with long-term headaches. People can be left with neurologic issues, sometimes meningitis-like presentations at times, sometimes cranial nerves that won't work right. Bell's palsy is actually one of the ways that we find Lyme disease a lot of the time when people present to the emergency departments. Heart block can happen, meaning that when the body should be creating heartbeats, the heart's not keeping up. And people can go into heart failure when they have bad Lyme disease. Yeah. Typically that doesn't happen after treatment though. Okay. So after successful treatment, I kind of think sleep abnormalities, muscle pain, bone pain, and overall fatigue are the biggest side effects that happen.
Is that like fibromyalgia? Okay.
Yeah.
Great, thank you.
There are so many infectious disease questions. I hope perhaps we can have you come back on because we haven't even scratched the surface. But before the end of the show, a couple other local, perhaps like pertaining to our population, infections. So fishermen or people who work in the saltwater marina environments. I have 2 questions because we had a common patient who presented with a rash on his hand that perhaps he wasn't too worried about, and then I recognized him that he was a fisherman, and then send to you. So the first thing is it's really important for people to tell their doctors in terms of kind of what they do necessarily for a living, travel, and give as much information as possible because it helps us decide what's going on.
Yeah, some pointers about soft tissue infections. With somebody who is breaking open clams and cuts their hand that way, or scallops, etc., they are at risk for saltwater bacterial infections, and they don't always respond to the same antibiotics that a normal kind of land-borne infection would. Mm-hmm. So if something is not responding to the first antibiotic given from a primary care doctor or an emergency department, getting checked out early and saying, hey, this doesn't look quite right would be a good thing to see your physician to get looked at by an infectious disease doctor. I have a patient who was recently cleaning a fish tank and ended up getting granulomas on her hand, lumps that are just fibrotic and not really painful, but they developed up her arm. And we call that fish tank granuloma. That's caused by a mycobacterium, which is a challenging infection to treat in a way because mycobacteria, kind of like tuberculosis, have thick walls and they need to be treated with multiple antibiotics at the same time to really effectively get rid of. We were talking about other types of things that come from puncture injuries and pets earlier on, and unfortunately a lot of people that get animal bites sometimes delay treatment or get the wrong treatment from where they show up, and it is a major problem for some bacteria. Some people that have puncture injuries that go deep into the muscle, they really need antibiotics. Mm-hmm.
So if the teeth break through the skin, really see a doctor because there could be something brewing under there. Yeah,
typically if it did draw blood, even if an area doesn't look infected, I would give a few doses of antibiotics just to prevent something from turning into a bad consequence from a dog or cat bite.
Cat scratch disease, you and I have actually shared perhaps a couple cases of that. I'm
seeing more in this area than I would expect to see. Sometimes that can be transmitted by insect bite from an infected animal. For instance, say there is a raccoon or wildcats that are maybe not in the greatest of health, and then that flea or that cat or either a direct or indirect exposure with a infected animal can go ahead and cause problems with swollen lymph nodes, aches, feeling tired. A lot of doctors who treat Lyme disease will go ahead and test for cat scratch disease because symptoms can overlap with that infection as well.
It's usually kittens actually versus cats that you're greater risk for getting scratched. Is that true, or is that not necessarily true? I thought I had...
I don't know how to answer that one.
Okay,
I'm
that's
not
okay.
positive about that.
That's okay.
But as far as outdoor cats, those would be the ones to really kind of worry about. Indoor animals would probably be at pretty low risk of being infected with that bacteria.
And maybe just close on tetanus shot. In terms of if you get bit by something, when, should you get a tetanus booster?
I think any kind of puncture injury should prompt somebody to make sure they're up to date on a tetanus shot, and if they're not, going to an emergency department. When I say puncture injury, say if you step on a nail, step on a tack, or lean on a wall that has a tack that's exposed. Tetanus is a bacterial infection that can produce a toxin, so the site can look totally fine, and then cause a syndrome called lockjaw, where the muscles tighten up because that bacteria produces a toxin that can be potentially deadly, that basically makes all your muscles contract. Nobody wants that. So I say get the tetanus shot if you have gotten a puncture injury.
Awesome.
Oh, or if you want to protect your family from whooping cough, because a lot of the tetanus shots are co-formulated with pertussis protection as well.
Perhaps in the future, if you would join us again, we could talk about, there's a number of other vaccines we didn't even talk to. There's a new shingles vaccine out, there's a number of pneumococcal vaccines to protect people against pneumonia. So if we'd love to have you back, because I think we could cover a lot more topics.
I'm glad we covered as much as we did.
Hannah, any questions pending for general medical questions, usually at the end of the show?
No general medical questions. We do have some more ID questions. Sometimes we do the lightning round at the end, so just do a catch-all here. You can choose one-word answers if you'd like. Can a Lyme test be false negative?
Yes.
Okay. How important is it to finish antibiotics, a full course that you were prescribed by your
I'd say
doctor?
very effective, and especially if you have leftover antibiotics. If you didn't follow that advice, don't start taking those antibiotics when you first suspect that you might have an infection from something else, because if a doctor wants to do a culture, say, in your urine, and you've already taken some antibiotics just laying around the house, number one, they might not work, and number two, they might impair your doctor's ability to get the right answer about what's really causing it.
Right. And closing back on tetanus shots, if you haven't had a puncture injury, how often should you get a tetanus booster?
10 years is the answer to that. Yeah.
Okay, great. That does it.
Brian, thank you very much. Again, for everyone who's listening, Dr. Brian Silly is available for consults for any infectious disease questions. He's in Fairhaven. He works with Hannah and I. We share the same office. It's actually great to work with him. Thank you, everyone, for listening. Thank you for the questions. Thank you for kind of being engaged. Hannah, thank you for the time. Josh, our esteemed producer, thank you very much. We will see everyone next week. Stay healthy, Southcoast.
Thank each of you.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, and throw it out of your vocabulary.
I had 2 blockages. I had to have a catheterization, and told me that we needed to see a surgeon as soon as possible. Dr. G made me feel like I was his only person that he ever did surgery on. You don't have to go to Boston. You can come right here to Southcoast and get the best treatment. I said to him, Dr. G, I guess I'm going to fall in love with you. He says, I know I'm going to touch your heart.